Today I'm going to talk about the experience of our CT perfusion program on patient care in the past months. Just show a few example cases and just to share our experience. This patient had a CT scan in a small hospital that's about 30 minutes away from our main hospital. Because of our radiologists went through the CT perfusion training, so now everybody has heightened awareness of the importance of reporting blood clot and treating patient with World Cup stroke. This patient at 8 o'clock in the morning presented with CT study of the head with symptom that correspond to this hyperdense blood clot in the left side middle cerebral artery, and showed some signs of ischemia already, hypodensity, loss of gray white matter distinction. There is some debate on what aspect score we should give. In the first glance, people say that that's a small area, maybe take a 2-point off from the aspect score for M1 and M2, and that's it. But look carefully, we could argue that the caudate nucleus, head, internal capsule, insular cortex, and lenticular nucleus are all involved. So we could take 6 point off if you look carefully. So then will be aspect score of 4. But that doesn't matter. At the time, our local radiologist reported that this is a hypertensive blood clot. The ER was trying to manage patient conservatively, but the radiologist persuaded them to transfer to our main hospital to be treated. So this one is at about 3 hours later and 2.5 hours later at 11 o'clock, basically showing some evolution of ischemia. Again, head of caudate nucleus, internal capsule, anterior limb, caudate, the basal ganglia, and the insular cortex, and M1 and M2 portion of the brain parenchyma. So it should be aspect score of 4. According to our established criteria, should not be intervened, but we intervene anyway. So the hyperdense blood clot is still there. So here is the perfusion images. We show that there's a large mismatch volume because the CBF less than 30% showed 0 milliliter. I think it's because of the ischemic core are dead already, that didn't show the relative flow difference compared to the rest of the brain. So basically showing that there's a large mismatch, and the Tmax 6 seconds showed which is the green color, showed there's a lot of delayed perfusion. So there is a mismatch between MTT and Tmax. This is how the bolus time mini CTA basically showed where we got the arterial inflow and where the venous outflow data point was acquired at these points, and the image quality is okay. Here's the angiogram, show the critical stenosis of the proximal ICA. here's the angiogram that went beyond the stenosis. Showed there's a blood clot in the carotid terminus extending to the entire MCA. There's not much flow, only with delayed filling of the left MCA territory. The microcatheter was placed in the carotid terminus and extending to the MCA. They dragged the whole clot out, and then eventually got most of the carotid terminus and the MCA back with some blood vessel perfusing the brain. However, still large portion of the brain was not perfused, and we couldn't find the clot that responsible for that occlusion. But I guess we got at least half of the MCA territory back. However, a day later, we showed a large hemorrhagic transformation of the area of stroke. This is a diffusion and a large hemorrhagic area, hemorrhagic conversion. There are 4 types of hemorrhagic conversion. The 4th type is like this. Basically, type 1 is small petechial hemorrhage, no mass effect. The second one is more confluent petechial, still no mass effect. The type 3 is the parenchymal hematoma, less than 30% of the stroke volume with no significant mass effect. Parenchyma type 2, which is the 4th type of hematoma, take more than 30% or more of the infarcted tissue with obvious mass effect. Example is like this. Type 1, petechial hemorrhage. Type 2, more confluent petechial, no mass effect. Actually, this one there is a mass effect. It's hard to argue because some are mass effect from the stroke, some are mass effect from the, I guess is we attribute all the mass effect from the stroke and not much from this particular hemorrhage. And then the type 3 is smaller hematoma, basically less than 30% of the stroke volume. What is a stroke volume? I guess you have to estimate it, use your mental calculation. This one is the type 4, which is our type. I discussed with the clinical team. They used to want us to tell them what type of hemorrhagic transformation, but right now they're not requesting it. So basically, petechial, coalescent petechial, small hematoma, large hematoma. This one have parenchymal hemorrhage, just like our case. You can see the hemorrhage in the lateral ventricle and a trapped right lateral ventricle. The patient eventually died a few days later. So for this one, I guess patient would have died without treatment anyway. But we intervened outside the screening criteria, which is an aspect score of 6 or more. But we intervene at aspect score of 4. So immediately, actually the next day, after knowing the hemorrhagic transformation of the previous patient, this patient showed up. CV activation, left side facial droop, also a local hospital that is maybe 20 minutes away from our main hospital. So I read this case remotely, seeing this hyperdense MCA sign that corresponds to patient's symptom without much evidence of dead brain tissue. At the same time, they did the CTA, showed a decreased flow in the right ICA, and then occluded right MCA. So we did not perform a CT perfusion just to save time for intervention. And you can see that ICA terminus and MCA are occluded. Somehow they are able to get the microcatheter beyond that area and scored it, and shown there's some M1 branches. I was told this case was very difficult. You can see the vessel irregularity. The vessel was difficult to open once, and then clot is difficult to remove. It's stuck in there. And then the interventional radiologist, actually the neurointerventionalist, couldn't get the clot out, couldn't open it, balloon this area of plaque. It did not budge because of the plaque is so hard, and also the balloon cannot generate high enough pressure to crack it open. The balloon is not designed to have the high pressure, just to worry about bursting of blood vessels. So eventually, this is the final result. It still didn't really open up, and here is the result. But at least no hemorrhagic transformation, and the patient is in physical therapy right now. After 2 weeks, and still did not pass away. So what I'm trying to say, despite of aggressive intervention, some blood clot is hard to retrieve or remove. This is 2 days after the intervention, evolution of stroke, and this is 3 days after intervention. Just more evolution of the stroke. The reason I mentioned about this case is because this FDA cleared this Viz.ai company to use artificial intelligence to detect large vessel occlusion from the scanner that will alert all the interventionalists and radiologists, just like the rapid program. So supposedly this one will be done in small rural hospitals that they can initiate the transfer process. What I'm trying to show you is, I show you 2 cases of rural hospital transfer to main hospital without success. Of course, when this company was trying to sell the program, they will say they're going to increase the success rate and the patient going to get benefit. I'm just showing that within 2 days, 2 out of 2 cases did not benefit from, even with such artificial intelligence software. This is a more recent case. The history is weakness, nausea, emesis, and headache, not even stroke. On the left side is 3:40 in the morning. The CT showed pretty much normal finding without any focal brain swelling. That's 8:20 in the morning. Now we see some subtle changes in the superior cerebellum. Subtle, but it's different than the other side. This is what the superior cerebellum looked like previously at 3:40 in the morning. This is 8:30 in the morning. This is 3:30 in the morning. This is 8 o'clock, 8:20 in the morning. So there's evidence of basilar artery territory stroke. Maybe this is a hyperdense blood clot. Same thing here. Hard to tell. Measurement is about 65 Hz per unit. That's measure it. 74 here, 62, 57. Let's try here. 57. So it's not a very definitive blood clot. CT perfusion was performed, showed clearly a lot of hypoperfusion of the posterior fossa and some ischemic core of superior cerebellar artery territory. So the CBF less than 30%, that's less than 70 milliliters. That means this dead tissue is not too large, and there's plenty of salvageable cerebellar parenchyma to be saved. And then the mismatch ratio means our risk of a stroke is large, and then the dead tissue is not that large, so it's worth doing. So this CT perfusion worked pretty well. And then the data is pretty good with good graphs. This is the beginning of the angiogram. Show the clot in the basal artery, almost filling the entire basal artery. After you clean it out, this is the basal artery. I forgot to show you the pre-angiogram, the CTA showed filling defect in the basal artery with faint right here, faint contrast in the basal artery, almost entirely occluded. However, the MRI study obtained on the same day after the intervention still showed a large area of middle and superior right cerebellar stroke, and also scattered area of left side cerebellar stroke. The next day CT showed more blossom of the posterior fossa stroke. Probably the stroke have extended to the left side more than the MRI, which is about 12 hours earlier. So even with cleaning out the basal artery, the stroke evolved. And progressed to the left side. This is another example of even with prompt intervention, stroke still occurred and progressed. So stroke care is very difficult, even with prompt intervention. Just to show you again, this is pre-intervention CT, clot in the basal artery. Now we clean it out, but still, this is early stroke in the right cerebellum area. Here's later stroke. I suspect there may be some progression of stroke in the left cerebellum. Posterior fossa is always difficult to evaluate because of this kind of streaky artifact from hard skull. It's therefore difficult to evaluate parenchymal abnormality, but I suspect there's maybe more stroke in the left cerebellum as well. What's not that obvious pre-intervention. Now the swelling and the compression of the fourth ventricle resulting in hydrocephalus, or no hydrocephalus then. So this patient will probably need more intervention to shunt the brain. This is an ongoing case. This is another case, a pretty atrophic brain with history of extremity weakness. This one is, there's some motion, so the study is kind of non-diagnostic after consulting with the dedicated 24/7 neuroradiologist by the on-call radiologist. the peak of arterial inflow and venous outflow was really delayed, so it's probably some cardiac output delay decrease, and blood have delay in coming in and coming out, so maybe cardiac output failure as well. Anyway, patient symptom later resolved. This is another case with extremity weakness. This one, the quality of data is pretty good. Showed no CBF abnormality and no perfusion abnormality. Maybe a slight delay in the left middle cerebral artery territory. Good data source, not much motion, and don't see much CT abnormality. And later had a MRI, showed that there is stroke, but it's higher up. We did not cover that area, so we are not expecting to detect it. We only covered 3 slices, so we didn't cover the stroke area. But that is the protocol set up by Rapid. I complained to them and we didn't cover that much, and their chief investigator, Dr. Albert, agreed. So they are going to help us to increase the area of coverage. Maybe now it's become 4 slides instead of 3, but still pretty small. Just let you guys know. This case does not have a hyperdense blood clot. This is another case, showed normal perfusion, all the good quality data, and showed a normal CT, no clot, and a normal MRI. This is another case, showed normal CT perfusion, good quality data, nothing on CT as a blood clot, nothing abnormal on CT. MR showed a subacute stroke in the internal capsule, posterior limb, probably symptomatic, extending to the thalamus. It's hard to tell on CT. And difficult to determine perfusion. Perfusion didn't show anything. Another case was suspect acute stroke, a lot of beam heart artifact. There was some hypodensity in the temporal lobe and the posterior aspect of the insular cortex. This is an aspect score of 8, and perfusion images show the perfusion defect. Perfusion mismatch of 7 milliliter. The CBF didn't show anything. Of course, it's too late because maybe it's already stroked out. So it's not reliable in the core measurement for CBF if you can see the hypodensity on CT already. So the volume to be rescued is not much. So there is no intervention performed. Data quality is good. CTA, show the acute occlusion here in the proximal M2 segment. And later showed larger area of stroke compared to the beginning here. Just normal evolution of stroke, this area versus this area. Of course, patient have a lot of chronic white matter disease. Maybe this is, it's hard to tell, probably this is more newer stroke, the more recent stroke that's evolved since this study, which this is March 10th, this is March 13th, 3 days later. So there is evolution of stroke involving more of the posterior frontal parietal region that wasn't that way 3 days ago. So for this case, again, I have always emphasized the benefit of CT perfusion is really draw our eye to the area of concern and scrutinize all the small vessels. Since we found dorsal vessel occlusion there, and then the aspect score fit, I'm not sure why we didn't intervene this one and result in further progression, enlargement of the stroke area. Therefore, implementation of CT perfusion does not necessarily translate into beneficial result. For example, previously I shown that we intervened too aggressively. This one we did not intervene aggressively enough. So CT perfusion does not matter much. Just review one more time. We only did how many slides? 4 cut. Just didn't cover high enough. So maybe in the posterior frontal parietal region that evolved stroke, it did not even made it into the picture. So that's a drawback. So hopefully we can increase our area of coverage. And just to remind that the criteria is for large vessel occlusion means M1 segment and ICA, not this proximal M2. Maybe in the future the criteria will be pushed out to include this kind of patient. This is a 50-some-year-old left side body deficit. Again, this is a 50-some-year-old left side body deficit. No acute stroke, but we missed reporting the subarachnoid hemorrhage here and there, very subtle. Perfusion images looks fine. Quality is good. No perfusion abnormality and no dead infarction core, and the CTA showed no filling defect in the main arteries, in the large vessels. Looks okay. The subarachnoid hemorrhage is better seen on diffusion images and the flare images. However, maybe they are too fresh that they don't have much hemocytic deposition, so it's difficult to see on GRE sequences. Well, the GRE sequence show, actually here you see some hemocytic deposition in the subarachnoid space. This big black thing is calcification in the superior sagittal sinus. Sometimes the subarachnoid hemorrhage is better seen on CT than MR of gradient echo images. So I have to really consider all the images together to find the subarachnoid hemorrhage. That's pretty much it for this case. No stroke with subarachnoid hemorrhage presenting as a stroke mimic. Another case, stroke mimic, suspect acute stroke, mass lesion in the right frontal lobe, with vasogenic edema, not cytotoxic edema, because it doesn't involve the cortex. The hypodensity does not involve the cortex, so that is vasogenic edema, suggesting tumor instead of stroke. CT perfusion showed normal. There's no infarcted cord, maybe slight hypoperfusion around the tumor. It's hard to tell. Good quality data. CTA again showed no filling defect in the large vessels with some enhancement of tumor. MRI showed the tumor. So this is like a case of a stroke mimic from the tumor. This is probably a GBM high-grade glioma. Is from frozen section resection. Another case, 70-year-old right upper quadrant weakness. Right upper extremity weakness. We see some calcification, we see atrophy, we see the diffuse white matter disease. There's the hypodensity in the basal ganglia. Maybe there's some hypodensity here, it's hard to tell. No blood clot in these circle Willis vasculature. CT perfusion showed no dead infarction core. There's no hypoperfusion. The posterior fossa showed mild hypoperfusion, but not in our suspected territory. Image quality is good. CTA showed basically normal filling of the MCA and the internal carotid. Bilaterally, actually, we care more about the left side of the brain because the right upper extremity symptom. Did not see anything here definitively, and later did a MRI on the same day. That's small stroke exactly in the cortical spinal tract, explaining patient's symptom. And then in the meantime, there's another one in the right side basal ganglia. Going back to CT, basal ganglia, that one is real. It's hard to tell. It's hard to tell the age, but it could be chronic, and turn out this one is acute here. The posterior limb internal capsule cortical spinal tract lesion here. It's hard to call. And too small for CT perfusion to be detected, and then there's no large vessel occlusion. There's nothing to be done interventionally wise, so this is another case. Another case, 80-year-old confusion, no blood clot in the circle Willis vasculature. CT perfusion basically shown no dead score, and there is no perfusion abnormality, maybe a slight hypoperfusion in the posterior temporal lobe. It's hard to tell. Quality of data is good, and CT angiogram. Looks pretty good. Just a lot of atrophy and white matter disease. MR showed no acute stroke. Diffusion looks okay. If there is some cortical abnormality, maybe remote ischemia in the right parietal lobe. It's hard to tell what's causing that. But no stroke. I just showed you 12 cases of stroke management. It was 11 cases have CT perfusion images. None of them are beneficial to the patient. directly because we're looking for a case that without CT perfusion we would have missed. We would have undercalled something. That patient would not have intervention. So far we did not have this kind of a picture-perfect poster case. We did raise awareness among all the radiologists about finding the clot, which we did, and then result in more aggressive intervention by our interventional colleagues, which we did. The results are so far disappointing, even with aggressive intervention. 2 MCA cases and 1 bachelor case, all 3 did not have a great result, which I showed early in my film. Other cases are either tumor mimics or so far just show you that this is a snapshot. We did not really select any cases to present. This is our experience from March 7th to April 11th, 2018. Now moving on to some other interesting cases. This is an 80-year-old with altered mental status, old stroke bilateral occipital region, and then that's pretty much it. We did not call anything else on the CT, but in retrospect we should have be more attuned to this hyperdense region of the M2 segment of the middle cerebral artery that verified on MR angiogram obtained a day later. You can tell that followed this vessel and out of sudden disappeared. Here, there, and disappeared. That is the blood clot in the M2 segment, and then correspond to this region of ischemia. So really, our job is to detect all those kind of blood clot in the vessels in non-contrast CT. By reading more of the CT perfusion and the CTA, we should increase our sensitivity of calling such clot. Maybe in the future, if the criteria extend into M2 segment intervention for the middle cerebral arteries, then this patient could be treated by thrombectomy. Who knows? But right now, there's no indication. But just to show you, this kind of a vessel clot can be missed and was missed. This is a companion case, stroke, acute change in status. CT of the head showed a really hyperdense clot in the M2 segment, and then with intervention showed that this clot is never be able to retrieve. Some clot are very hard to remove, even with intervention such as this. But they did inject that area, so later showed some staining. So I was at the time was in trouble telling whether that's just contrast stain in the area versus hematoma. So, but a few days later, actually the next day, it just shows severe decrease in density of this contrast. So the hematoma doesn't go away like that. That's a contrast. Here's the follow-up MRI of the stroke. This is a follow-up CT. Show the stroke, and then the contrast gone. Used to be there. The MRI. This showed the ischemia, cortical ischemia, and stroke, but no hematoma. The hematoma usually doesn't follow the cortex like that. They should be should look like a ball with maybe onion-shaped or heterogeneous instead of this kind of a gyroform density. A change of topic. Another interesting case: young patient, 40-some-year-old, with history of left parietal mass. Patient metastasis. We measured the mass, everything, no problem. Except that we missed something in this picture on March 11th. This is an MRI follow-up on March 12, 2018. We missed a lesion here that was not seen there. This is the hypothalamus extending to the pituitary stalk. That is the reason I know, because the symptom fit newly developed diabetes insipidus. Drink so much, peeing all over patient himself, and then they want to find out how to explain this diabetes insipidus. And this is the metastasis that wasn't there before. Other metastases are bigger, of course. Just an interesting case. Another case, interesting case, was 84-year-old CVA history, headache. The history of CVA present with headache. Okay, just showed general atrophy. The CT just very hard to call anything. But MRI also missed this. The lesion was missed in here, because I just let you know that diffusion images are very helpful, not only for the brain, for stroke, but also for scalp lesion, skull lesion, and skull base lesion. And then now we look again, this contrast enhancement of the occipital count now, and show the tumor infiltration with the compression of multiple nerve here. Cranial nerve 9, 10, 11, 12, they all can be compressed. So just show you that some areas hard to call, that was not called on MRI brain or see the MRI of the cervical spine, because of this area is very subtle, and even CT is hard to call. But this is easy to see on the PET CT. Another case, acute aphasia, stroke protocol. We'd call the normal, basically nothing acute, but you can tell the difference between the left and right cerebellum was not called. It is very difficult to call subtle ischemia in the posterior fossa, especially this kind of non-specific aphasia symptom, but later does show the stroke in this area. So just look at asymmetry in posterior fossa. I guess that's the best help that we can get. Especially with comparison to previous study, which is on the right side. This is a study a month ago. There's no such asymmetry in the very inferior cerebellum versus here. Very subtle. Nobody can fault this kind of a mess, but we just want to share with everybody to increase our sensitivity for subtle difference in density. When in doubt, the MRI will be helpful. That's pretty much it for the interesting case and our summary of 11 or 12 case of CT stroke patient that our